I'm trying to help you for what you actually have. And then they're like, well, I saw on whatever show that they did this or this, and you're just like, that's not a
Yeah,
thing.
we didn't go get you, like, somebody
Yeah.
had to call an ambulance or you came to the emergency department. Hey, everybody, I'm Kaylee. Welcome back to Banter at the Bedside. Today, we have a fun episode, and we're talking about when patients refuse care. So, I think a lot of us have dealt with this in lots of different situations, whether it's inpatient, outpatient, maybe you work in the emergency department, adults, peds. I mean, I think it's everywhere. So we're just going to be discussing our experiences with it, what are our opinions on it. And as always, these are our opinions. They are not advice. We don't represent any organization. And that's what we have for you today. We have a couple special guests with us today. I have Cody. He's one of our coworkers. He works with us on CICU. He's been a nurse for over 10 years. He's worked in several places. He's been a travel nurse, and he's here to lend some of his personality and comments. And we also have Michael with us.
Hi, my name is Michael. I'm a ICU physician. I've been working in mainly cardiac ICUs and cardiovascular ICUs for about 10 years now.
Excited to have you.
Thank you.
Welcome.
So, I think this is an interesting topic because patients come to the hospital and then we want to help them, but then they refuse it or they kind of cherry pick. And for me, it gets frustrating as a provider, and it gets frustrating because then and Michael, you can maybe speak to this, we're expected to like try and offer them other solutions, but sometimes there's not. Like, we're supposed to go in, that's what they say, we're supposed to go in and offer, like, even if they're going AMA for a certain reason, like, we're supposed to go in and try and kind of meet them halfway. I remember there was one time, and this was when I was pretty early as a nurse practitioner, like probably my first year, and the patient had a cardiac arrest, ended up needing dialysis. The night team had put in a central line and couldn't get in touch with the family, but they didn't put in a dialysis line. And then the next day, we needed to do dialysis. We were max pressors, bicarb drip, pH was still 7. So I called to get consent for dialysis and the dialysis line. She wanted dialysis. She was okay with it, but then kept refusing the dialysis line, and then was mad because she's like, well, why didn't they put in the dialysis line last night if you knew this was going to happen? And I'm like, I don't know. I was, I'm sorry I wasn't here, but we cannot run dialysis without this. And she got so mad. It was like an hour and a half of us talking to her to understand. And I'm like, finally, we reached a point where I was like, that's fine. You don't have to do the dialysis line, but we absolutely cannot run dialysis without this line. Like, there's no other option at this point. So if we're not going to do it, we're not going to be able to do dialysis. We need to talk comfort. And she didn't like that option either. Eventually, eventually we got her to understand, I think, and agree to the line. But then she submitted, like, she called and complained and like wrote a letter complaining about me that I didn't provide enough options. And then I had to talk to my director about why I didn't provide more options. And my director was a nephro NP. And I'm like, what other option is there? And she's like, yeah, I guess that's kind of true. So
Kind of true. It is true.
so
Not kind of.
it's interesting to me because it's like, I don't know, how do you balance that? What can we do sometimes? Like, when you're in the ICU, especially, like, there's very few options we can offer you. If you don't want it, that's kind of it. There is a reason you're in the ICU. I don't know, if you guys had like other experiences, or what are your thoughts on my experience?
No, I actually think that that's a really good example where it's like it's just not matching up, because like I would think of ones where they're like, I want everything done. And then you're like, well, let's put in a central line. And they're like, well, I don't want a central line. Or you're having to like go in and explain it. But like yours is just like, they want dialysis, but won't do the dialysis line. Like, that's Like that, there's clearly like a disconnect in that type of stuff with it. I always run into this stuff where the families like do everything and then you're trying to like get consents for stuff. And then they're like, whoa, 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 like, well, let's go over them, like all the stuff. And you're going through all the stuff individually. And it is kind of interesting when you have somebody that says that they want this done or want that done, and then now they're saying like they don't want an arterial line or they don't want a central line or they don't want, but they want like full court press. They want to be on a ventilator. They want to be on pressers. They want to be on, and then it's just like, well, are you in or are you out? And when you have like 1 foot in, I think that's the most frustrating. I think if you're just across the board, I don't want any of this. I think for me, I'm more willing to accept that. Like, that's fine. You don't want any
Uh-huh.
lines. You don't want any medications. You just want to, have things be peaceful. That's fine. Or obviously the other way where you're like, let's just do everything, blah, blah, blah. But like it is like you're talking about the pick and choose. Like I do want this, but I don't want that, and I do want this, and they don't line up with what makes sense for the care.
Yeah.
And that is hard because it is hard to try to balance where it's like, do I have to have it? In your case, it's very clear cut. You can't have dialysis without a dialysis line. But if you have somebody, you're looking at hospital policy, and a lot of hospital policies will say you can't run Levofed over X amount through a peripheral IV, and then they're refusing a central line, and then you're just like, well, where do I go from here? They want to have a blood pressure, they want to be alive, they want to
Hmm.
have
Uh-huh.
have these things, but then they don't want other things.
Yeah.
Right. And they refuse just enough that you're still stuck with almost like they're going to blame us when things don't go well, but you're not allowing us to do the things that we need to do to try to make that happen. And I'm with you. I'm like, you don't want any of it? Cool. Like, bye. That's good. But then you want us to save your life or save your family member's life, but you won't allow us to do the things that are going to actually do that. Like with your thing with the dialysis line, Abby, do you think that was just like she wasn't understanding or like that was a level of education or
No, I think more what it came down to is she was upset that he was going to have another procedure and that the original central line put in was not a dialysis capable line.
uh-huh.
Um, and part of me kind of understood that, and she didn't understand why we couldn't run dialysis through that. I mean, at one point, I'm like pulling up pictures to show her like the different sizes of like, I can't do this. And it's like, I would love for if he was more stable, I would love to just, you know, wire through the current one and swap it out. But he was on max pressors. We couldn't afford to pause them to do
Uh-huh.
that. So the only option was, yeah, sorry, unfortunately, it has to have a whole nother central line. And I think at the end, we ended up like the deal was we'll put the new one in and we'll take the other one out, which I know really sucked for the nerves because then they're having to manifold. Because again, we're on like 2 pressors, bicarb drip, sedation, intubated, like antibiotics, the whole works. So then we got a big manifold. But I was like,
Like, okay, so we're actually going to go backwards. Cool.
I was like, okay. I think it was like one of the few times that I was like, all right, I'll whip out my IV skills and I'll get you some good
Uh-huh.
ultrasound guided IVs for some of these things that can go peripherally.
That's
Yeah,
crazy.
that when you brought up this topic, that was like the first thing that I remember because it was so frustrating because it's like, okay, but you want him to be a full code still. You still want us to do everything, but you don't want this one thing. It
Uh-huh.
was just, and I try to remind myself too, like it is a bad, like it is a bad day. It is a lot of decisions, but that's where sometimes when it's like do everything and you have the families that are like, you go and you start to consent them and you're telling them and they cut me off and they're like, just, yeah, whatever they need. I'll sign whatever.
Uh-huh.
And it's like, no, actually just listen so you can say that you listened, but I know that they're not, or full comfort or full like nothing.
Uh-huh.
But those, as Michael said, the 1 foot in, it can get to be frustrating. Or it's like, I
Yeah.
don't want when I've had some, I don't want pressers, I don't want life support, but I'm a full code.
Mhm.
It's like, well, if you code, I'm probably going to need some life support temporarily.
Mhm.
So it's
And
like,
it's like, at what point are we letting the patients and families dictate the care?
yeah,
Like, we have, or what we've always been taught since I started working on our unit, was patient family centered care, right? We want visitors. We want people at the bedside. I want people involved. And that's good, because that's a support system. But we are the medical professionals. I mean, well, I mean, I went to school. I've been working there for a long time. You've gotten an advanced degree. I mean, Michael, went to school for a decade to become an MD. You're an intensivist. And then somebody who just walks off the street who probably doesn't really know what they think they know is now telling us how to do our jobs. And I think that can be extremely frustrating because we are trying to do this for a reason, because we want to take care of people. So as a nurse, it's extremely frustrating, but I would love to know how that feels for you when you've been to school for so long and you've gotten all these certifications and taken all these boards. And then some guys like, well, actually, on Google or on Facebook, they can't, that's actually, we're not supposed to do that, or you can't give them that.
Sure. Yeah, yeah. No, I mean, it can be frustrating. It's one of those things that patients or patients' families certainly feel out of control, right? Like a lot of times their family wasn't sick and then now they're very sick, and it can feel bad. And I think a lot of it is for them to regain a sense of control, like I'm contributing, I'm participating. And so they'll a lot of times say like, no, I don't want this. Or they'll say, oh, well, let me think about it. Right. And that's their way of just being like, I'm the one that's doing it, when you know what the ultimate answer is going to be. Or if they're like, I need to talk to my niece who's a doctor, or my niece who's a nurse, or like everyone's got like that whatever. And then you find out that they're, like they do something that's nowhere near related to critical care, and that they're gonna know some, but like to understand like all the ins and outs of this type of stuff, it's like, sure, like that's fine, you can like talk to them on the stuff with it. But I've seen that in a lot where they're wanting to have that sense of, yes, it is my decision, versus just saying like, do all the stuff with it. um Most of the time you can try to just reason with people and do it. So it's not like every day that I'm having those arguments. Um but it is when people get specific, like you talked about, where they're like, I want this, or I don't want this in particular. One that always comes to mind is when people say like, I, I'm DNI but not DNR. So I want you to code me but not intubate me. And you're just like, the other way makes sense. Fine. Like if you want to
Yeah.
intubate somebody, but if your heart stops, but if it's like, I'm going to be pushing on your chest and breaking ribs and trying to keep your heart going, and then just bag you for the rest of your life, like I don't understand. Like if you don't wake up but we get your pulse back, then we just keep bagging you or throw, like it's like there's so many things like that doesn't work. Like I get that what you're saying with it, but it doesn't work in that scenario. So that can be tough, where you're just trying to figure out how to navigate it so that the family or the patient feels like they're being heard. But also trying to recognize just care in general and how it's hindered.
yeah. I think too, and I love my nurses, but I think too, sometimes it doesn't always feel like, not like it doesn't feel like a united front, but it feels like the buck gets passed a lot quicker to us, where it's like some of the, like when it comes to like refusing medicines, I feel since I've started as an NP to now, I'm getting called into the room much more about refusal of medicines, and some of them are really important, and I'll go in and then it's like, oh, did you educate them about it? Did you explain what could happen? And then it's like, no. So that too, I think sometimes makes it a little bit more confusing. I'm not saying you two do it. I know you two don't, but I think there are some nurses out there that are more concerned about getting the Daisy Award and being
Second
liked
best.
being
To be
liked by
honest.
the but but being liked by the family, that they don't want to be kind of a contrarian. But having worked in both roles, I can see how the nurse at the bedside being there and having a much stronger relationship than I can build because I'm taking care of 8 other patients or 24 other patients, whereas the nurse is not. Having a strong nurse that comes in that the family trusts also helps sometimes in those conversations. Does that make sense?
Yeah. The nurses shouldn't just be like, "Oh, well, no, that's not my job. You gotta go talk to him." Like, and you can do it in a way that's not even like being contrary. You can just say like, "Well, this is why you're on this. This is the importance of it, and XYZ."
Yeah.
Um, so I don't know why that would be a hard
Because
pass for
I'm
a
gonna
nurse.
educate them to the best of my ability. If it's something like out of my scope, then
Sure.
yeah, I'll get the provider. But
We also have to document first dose education on new medications. Like we're putting that in our chart that we provided education to the patient and the family. So are they really doing it? You should know what the med is and why they're getting it. So why can't you tell the family?
Yeah.
and the
it's
patient?
probably also
Mhm.
the bigger piece to it. It's the lack of
Well,
knowledge.
and I've never been at the bedside, so I cannot speak to it on the thing with it. But having just been around people speaking about things with it, the way you present the medications goes a long way too. This is not related to medication, but I know like one of the big things in the ICU is like mobility and like getting out of bed. And you walk by a room
I just had a
and
PTSD flashback.
I was going to say, I think Kaylee's triggered from you.
but you
Pedal,
hear
pedal, bitch.
Can I get 2 cranberry juices?
the there's a difference between like you're gonna get out of bed, here is the chair, get prepared, we're gonna get your meds and we're gonna get you out of bed into a chair, versus walking up to the patient and being like, you don't want to get out of bed right now, do you? And they're like, no, I don't want to get out of bed right now. And they're like, patient refused to get up out of bed. And it's just like if you like, it's ways of presenting it. I think you can do the same thing with medication. Like, these are the medications for your heart to get your heart better, versus being like, do you want to take these medications? No, I don't feel like taking them right now. They're hard. It's hard to take them or whatever. And be like, patient refused the medications. And so I've seen like where it's just like it really depends on how you're presenting what you're doing with it. And it goes a long way. Like, so much of what the patient's experience is going to be the nurse experience, because I'm not there at the bedside as often. If I'm at your bedside a lot, things are not well. So
Yeah.
like most of the time I'm not at the bedside. And so it does depend on the nurses.
Yeah.
Yeah, I feel like it's early to set the precedence with your patient, like early on in the shift. So that way at 4 o'clock in the morning, when you're telling them we're about to get up soon, they're not surprised, or you kind of just have to set the expectations early on in the shift.
Yeah. It's kind of like when you're talking to toddlers, you give them simple choices, and that way, no matter what they choose, you're getting what you want out of them. And it's not because they're not adults, but they're sick. And so they're looking to you. And it's like you're saying, it's like, how am I presenting this? Like, well, we're going to get up today. So we can get up now before we give your meds, or we can get up at maybe at lunchtime so you can sit up and eat your tray. And then they feel like they have a say in it, which they should. But either way, they're still doing what they need to do.
But yeah, the presentation does matter.
And I think too, like, and Abby and I have touched on this before, but like when I was a newer nurse, I was much more apt to not fight with people, but like I wouldn't let it go if they wanted to refuse something. And I'm not going to be fighting with them as much now. And that is when I'm going to pass it on to the next person. But if you're adamant that you're not going to take, I don't know, the Colace or the Lipitor or whatever, like I'm still going to tell somebody, but I'm only going to tell you a couple times and then that's on you. So that's fine. I'll document refusing that I told the provider. But there's some people you're never going to convince of anything.
So I have a question. I've never worked at a hospital like that, but I know that there are hospitals that when you come into the ICU, it is automatically assumed that you've consented to like A line, central line, like basic lines, not necessarily intubation, because that's like a bigger deal to be on those things, but to be like, once you step into here, there are certain things that are auto done through there. that certainly makes it easier, right? Like if you're going to accept somebody to the ICU, you're saying it is a critical care unit. We are going to do critical care things for you. We can only do this with certain amount of stuff. It's up to our discretion on whether or not they need it, but you're kind of like auto consented for it by agreeing to come to the ICU. Do you think that would make things easier? Do you think that creates more issues? What are your thoughts?
Oh,
That's a 50-50.
It's like interesting as I sit here and I'm like, just either consent or don't consent. So you would think I would automatically be like, yeah, like blanket. But I think so many of the patients, especially in hospitals like you work in and where we work in these rural communities, there's a lot of times that these family members, when they're directly admitted to the ICU, haven't even seen their loved one until they're on our unit. And there's been times when it's like, do everything until we get there. And then they arrive and I start to consent them and they're like, dad actually wouldn't want that. Like, I remember there was one time we just assumed that they would want everything. And so I put in a cooling line emergently because we were almost out of the cooling window. And the daughter showed up and I had just finished the line and she's like, dad wouldn't want this. I want to stop. Let's withdraw. And I kind of felt bad because I was like, oh, in his like last hour of life, I just sat and did this line that he ended up not needing. So I'm a little torn on that. Like,
plus all the work you did.
yeah.
I think my worry would be at teaching hospitals
Mm.
that kind of gives you a free pass to do procedures on people if they don't actually need them just for practice.
That's what I was thinking. Like, are we doing?
So like if I think that could work, but I just feel like there would have to be so many caveats. Like, yes, that if they need it, but like if they need it. But even still, if you're coming at a person who's completely with it with a needle and they're like, no, what are you going to do then? Okay, well, you
Sure.
got to go. You can't kick them out, right? So how
Sure.
does that work in
Yeah, I
these
mean,
hospitals? Is that really?
like I said, I've never worked at them on the things with it, and I mean, you have a good point. I mean, it's such a gray area to say like, does this person need this line? If they're on 3 of Levophed or however you want to measure your dosage on it, like that's not a lot, but you could easily argue, well, they're on something, they need a line, or you could easily say, well, they're pretty stable, they're not really going up on it, we could probably just do peripherals. Like there's not a black and white answer to procedures. So I think you do have that risk, like you're saying, of being like, oh, well, I have somebody here with me that needs a line, let's go ahead and do it, versus like, is it the right thing to do? But I mean, that definitely puts it in the provider's court, though, to say like it's their judgment on should it be done or not. But yeah, I don't know how I feel about it. I think sometimes it's frustrating when you can't get a hold of people, or they're like, let me call you back and think about it, and you're like, I don't know if I have that time to think about it. And then you're like, well, am I doing this emergently for like the good of the patient, or am I trying to like wait in case they do it? And it does make it harder when you're making that full decision, because you have to live with that decision, even if it's something real small, that you're doing something that you think is the best, and that's what you just have to go on. Like you're saying with the cooling line, like if you can't get a hold of family and you have somebody that meets criteria for it, and you think that gives the patient's best chance for survival, then you have to go by, this is what I think is the best for the patient.
Yeah, I mean, you want to
And
assume that the
yeah,
person has integrity and is trying to do the right
yeah,
things.
Yeah.
And I think overall, I mean, that's most of people. I just know how it is when people want to get their procedure done.
sure.
Well, also, we had an APP that's not on the team anymore that would come in and be like, oh, I really just want to stick a needle in someone's neck today.
I mean, you can be excited about your job. You can like your job, but
they would literally come in and be like, oh, I really want to do a central line today. I want to see that flash of blood. I get a dopamine rush. And I was like, you're
There's
So
nurses
weird.
like that, though. They wanna stick everybody. I'm like, "I don't care. You can go ahead. You can get that IV from me. I'll sit down."
And
But
It's procedure I have a chart on.
yeah, exactly. I guess okay, here's my thing, and I just wanna say, like, I believe in everybody's right to refuse. Like, it's your body, and I think especially now with everything, like, you should have autonomy of your body and the medical procedures that you want or don't want done, if you have capacity to say that. And if not, hopefully somebody else can speak for you who you trust. But I think my problem is that when you have come to the for us, let's say you have come to the emergency department either at our hospital or somewhere else, and you have ended up in our ICU because you were that sick, and then you're refusing stuff. So you trusted us enough, like you know you can't manage this by yourself. You've come to the hospital, you're so sick that you've gotten into the ICU, and maybe not, maybe you're just on a floor, but you're admitted because you need help because you're sick for whatever reason, and you're refusing what we're recommending. Like, I don't think that that's fair. I don't think that's just fair to the other people who want the care, and maybe you're holding a bed that they can't have now. The people who come to work to try to do what they're supposed to do, you know, you're causing a bit of a problem. Not saying that you might not be okay, but why come at all if you're not going to listen to the experts?
Well, I don't disagree with you. I think the problem is like between the internet and TV shows and just things is like they're like, "Oh, you're wrong. I want a second opinion," or like, "That's not what I read." Like there's you lose that trust, and you think you're like, "I came to the hospital for this," and then you're like, "Oh, well, it's actually this, and you need this and this," and they're like, "No." And then it is like, I'm trying to help you for what you actually have. And then they're like, well, I saw on whatever show that they did this or this. And you're just like, that's not a
Yeah.
thing.
Well,
yeah.
my aunt, she told me,
Yeah.
blah, blah, blah. Or my Facebook group, the mom said, you're not supposed to do this.
Well, do you guys remember we just had one, and I anticipate we'll probably see it more, but we had that one family member using ChatGPT and
Oh,
putting in the vent settings on ChatGPT and asking it to tell us, and he would call us into the room and, tell us, well, ChatGPT says we need to put this
oh,
good every time he wanted to talk to us, he was pulling up ChatGPT. And then, and I think some of it started with, he was on one service and the patient had valve disorder and they didn't really know how to manage it, which is how they ended up with us. And he kind of lost trust in the system. But I just remember we were on day like 20 with us, and the family member calls me and the attending in the room and is explaining to us what ChatGPT told him pulmonary edema is and how to manage it and what we need to look for. And I had a pulmonologist on. We're in a cardiac ICU. And it was just like, sir, I know how to manage pulmonary edema. I promise you. I do this every day of
every
my
day.
life. But that he was one that he would refuse certain things because ChatGPT told him to refuse it. And that got really frustrating. I think that's what you're touching on, Michael, of like they see it on TV or they are now asking AI and they use it, they trust it more than us. And it gets, that part gets frustrating because how am I supposed to argue with?
And
I'm,
also, he's not even the person who's in the bed, so he's speaking for his wife, and it's like, but how do we know that she would agree with this? Like, how do we know that she would not want us to do what we're saying? And I think that's what makes me frustrated too, because if you want, sorry, if you want to fuck yourself up, like you go right ahead. But now you're doing this to somebody else, and I mean, I have to assume that you know that what they would want, but how do we? I mean, I don't know how people who work in pediatrics do it with parents who refuse recommended things for their kids. Like, because I think it's bad enough in the adult world. So, and I think that's when we have to get like the lawyers involved or the ethics involved if it's something that's really detrimental. But we all know what the outcome of that is. We have to, usually, we're stuck at what they say.
Mhm.
I think that's really frustrating. And then when you have to get like legal things involved, it's always like another layer to protect yourself.
I think it got worse. It's gotten worse since COVID. I think during COVID, everyone at home started looking up symptoms of everything, and it is slowly progressed over the past 5 years. And it's almost like a sense of entitlement. They definitely they want what they want, and they know what they think they know, but they actually don't. So this been it's kind of frustrating since COVID happened. The family members,
100%.
Oh,
They've
yeah.
done their research.
Yeah, well, also they weren't they weren't allowed in the rooms, and a
Mhm.
lot of the people like understood what that meant, but other people were like, "Well, what are you doing to my family member that you won't let us in there?" And it kind of like breeded that mistrust
yeah,
of, uh, "You won't let us see the patient because you're doing stuff that you shouldn't be doing," or like, "We're reading up on this and we're doing things that it did make it tougher." I mean, it in some ways, it it can be nice, to not have. I know it sounds bad, but when, right before to say a personal story, right before my mom went into hospice when she was in the hospital, my dad it was during COVID, and only 2 people were ever allowed to visit. It was only 2 total visitors, and I wasn't one of them because I was not originally there from being out of state, and so, like, I was the physician in the family, and I could only hear back from stuff from my family. And it is interesting to be on the outside of it and just hearing stories from non-medical people about things that they heard with people in the room and trying to figure out what it all meant. And
Mhm.
then like listening and my dad getting frustrated, and then him being not he was never confrontational, but he was, like, very direct with the doctors, like, "What about this? What about that?" And would ask these direct questions, and being on the other side of it, um like you want to make sure you do everything, but if every time you walk into a room, you get bombarded with like 5, 6, 7 questions. Why are you doing this? Why are you doing that? What's going on? It makes you subconsciously not want to go to that room as much.
Yeah.
And
Yes.
and I try everything I can to be like, no, I need to treat this patient like I would treat any other patient if they didn't have family in the room. But it can be time consuming and exhausting if every time you go in the room, it's a 10-15 minute ordeal of having to like explain everything. Like I know I had one case and they're like, what's wrong with my daughter? And I spent 20 minutes in there with like 4 family members. And then I was doing a quick walk around and like 45 minutes later, and they were like, "Hey, can you give me an update on my daughter?" And I was like, "It's been 45 minutes. Like I can't. Like I mean,
The
she's
update is
in
There's
I need
back.
a lap around the unit. Like,
Yeah. Like
there's nothing to update.
I'm just trying to visualize everybody and make sure like they're where I think they are. And it was just like I can't spend another 15-20 minutes in here repeating what I just said. And so like, but those are things that do make it like interesting, like dealing with patients on stuff with it or dealing with patients' families.
yeah, I mean, I I feel like most of us who worked during COVID did not agree with the visitation policies and things like that. We were dealing with an unknown. Everybody was doing the best they could. I know our facility, we had iPads. We tried to FaceTime family members. We tried to call. A lot of the nurses were very outspoken about families should be allowed to come up if it's getting towards end of life and we
Mm,
were shot down.
sure.
But the families don't know that, and so I think that you're right. Like it created a lot more mistrust, even though there probably was already some. But it's like we're still being punished for that. I I don't know. I still feel like we're being punished for things that happened then that we also didn't agree with.
yeah. And it put us in a different light as nurses. They looked at us different
Yeah.
during that time. And
I th-
working when I worked on a primarily COVID in a COVID ICU during COVID, and people were dying every day. And so the amount of people dying every day and their loved ones not being able to talk to them, even leading up to them getting intubated, where they were able to talk, it was, I can see sides of it.
Hmm.
I
Hmm.
think the interesting thing too about COVID is the rest of the world outside of medicine had to experience what it's like to make discoveries in medicine. I think that's a piece that's not talked about. Like, yes, keeping people out of the hospital definitely didn't create trust. But, we started, I remember 2020, and there were things talking. And I remember telling people that asked me, I was like, you should be more worried about the flu than this virus.
Right.
And then it's like 2 months later, I'm eating crow and I'm like, oh no, I was
Yeah.
wrong. And then we had to keep doing that, but that's how science is. And we understand that. But a lot of other people that haven't had to work in science since college or even high school forget that that's kind of the scientific process. Like, we had an unknown, we didn't know what worked, and then the virus kept changing. It's almost a year later that people started losing smell and taste from it, and all of a sudden that's a red flag symptom, and we've never had that in a virus. So I think that's a piece that we don't always talk about either, that, well, we did say a lot of things, but we didn't know. We were doing the best with the information that we had, but that can create distrust too.
Yeah.
Well, this happened a lot. Like, this has happened throughout medicine, right? Like, if you look at anything that we do for treatment, people even talk about certain things where they would say, oh, you should give steroids to people that have this disease. And then 10 years later, they're like, actually, we don't recommend steroids in this disease. And then in 10 years later, they're like, wait, we re-looked at it. We think that we should give steroids in this situation. But it's not published, or it's not like brought to the public as much as it was for COVID. And so, like, when I was an intern, there was a drug way before y'all's time called Zygris. Zygris? You've given Zygris?
I've said before whose time?
I mean, but I was an intern. This was so many years ago.
Oh, yeah.
And
I was probably in middle school.
Yes.
But this was like the drug for sepsis. It was supposed to just fix sepsis, septic shock, the whole thing. And there was a study done by the company, and the company was like, look, we did this study. It's an amazing drug. And we started giving it. And it was supposed to stop the inflammatory pathway of sepsis. And it was supposed to like stop all the we didn't really care about cytokines up until COVID hit, and all of a sudden everyone started talking about cytokines and trying to do all this stuff. But this was what it was supposed to do. And I remember I gave it to somebody when I was an intern. Like, I didn't, I was an intern, but like the team did, like the attending did. And then I came back to the to the ICU a year later, and they were like, oh, this study came out, like the repeat study, and it was killing people. Like, it led to just people bleeding to death. And it now has a black box warning that's like, absolutely do not give this medication. People will bleed to death if you give this medication. But for years, we gave this medication because it was said that was recommended, right? And it's published and it's out there that we gave this medication for a long period of time. And that was the information and knowledge that we had. But like, people weren't throwing this up on the internet and being like, hospitals are trying to kill us, like, don't trust the hospitals. Look at these medications they're giving. And then that's what happened in COVID is we were like, this medication should work based on X, Y, or Z. And then we gave it and they're like, this medication does not work. And then you had one group of people that was like, you're killing us by giving us this medication. And then the other one's like, it actually does work. And now you're not letting us have it. And it was just, everything became so in the public eye that it just has never been in the public eye, that people started paying attention. Like, it used to be, you're a doctor, I trust you. Do what you think's best, to like, you can't trust the doctors. They're trying to give you stuff or do stuff.
Yeah.
And I think that did come from us having to be like, on the fly, be like, we're trying to survive a pandemic. Like, this should help.
Yeah.
Well, I think also at that time, healthcare sort of became, that's when it started getting so politicized, and that was
Mm.
just like a whole other thing, which is a whole other topic. But it really, I mean, it is stuck, and it,
Yeah.
we've all seen it since 2020. Like, it's really, that's how it's been. But there again, like, you're in the hospital, don't trust the hospitals, but you don't just end up in the hospital. Like, either you
Mm.
come there or somebody calls 911. Like, you don't just wake up in the hospital because we didn't go get you. Like, somebody
Yeah.
had to call an ambulance or you came to the emergency department. And I think that's like the struggle for most of us. And there's like a whole spectrum. So like I had a patient a couple weeks ago who wound up in the ICU because they got so hypertensive during their procedure. They went into flash pulmonary edema and they almost got intubated. So they're up there and they're on Cleverpex and nitro. I'm titrating them both. Of course, they don't have an A line. Why? So their cuff's going off like every 5 to 10 minutes. And so he just got tired of it. He's like, this hurts. I'm not doing this anymore. I was like, ugh. Okay, well, I was like, this is why you're here because you almost died. Like, I need to get your blood pressure. And I was like, bargaining with him. I was like, well, let me just get it every hour. Like, I'm trying to talk to him. And finally, I was like,
Mm.
okay, whatever. I hope you're fine. And I told, my provider and the attending, and they were like, okay, that's his right. We documented it. I ended up, you can believe it, sweet talking him enough he let me put it back on and take it once an hour. He ended up moving out. So that's like one layer of it where it's like, you really need to let me do this, but I can't make you. But I want to ask your opinion. There was a situation years ago. This patient tried to leave AMA and psych came and examined them. They said they don't have capacity. So they weren't allowed to leave. However, they stayed, but they were refusing everything. So they wouldn't let us put them on the monitor. They wouldn't keep their IV in. They wouldn't stay in the bed. We couldn't run. And this person had like a swan and stuff. Like they needed
Mm.
multiple medications, like very, very bad off. And my attending let them refuse all of that for like half the shift. The guy's like coming out. He's like cussing me out, like he threatened to throw something. He didn't actually throw it. And I'm like, look, I get it. You're trying to reason with this man, but he doesn't have capacity. It's been proven that he doesn't have capacity. So you're forcing him to stay here, but not letting us do anything to help him and basically waiting for him to code. And I was like, there's got to be some middle ground to this. And what ended up happening is that the police came. There was like a 4-hour physical hold to try to give him enough IM shots to get him calm, to get an IV so that we could start some medications. And he ended up getting like intubated. Another swan put in. Like he was so, so sick. And I'm like, I just don't know how to navigate this because I'm just like the nurse stuck in here and like I can't do anything, but you won't let the man leave. So if the patient is deemed to not have capacity, there's nobody else there to speak to them. Are we just supposed to force them to do everything if they can physically still say no? Like,
Yeah.
that was like
No,
one of my worst shifts.
I mean, that's hard, right? Because if you feel like you're doing the right thing because you're not letting someone leave who's sick. But like you're saying, they now don't have capacity, which means in order to take care of them, if they're still refusing and they can't refuse because they don't have capacity, means you have to like strap them to the bed or chemically sedate them or do something that now feels like you're doing something more. And
Yeah.
I could see how that's hard. I still think if you're saying that the person truly doesn't have capacity, then you have to default like what's best for the patient. Like if they need medications, if they need this, if they need that, then you have to figure out a way to make it happen. So yeah, you can't pick and choose when they have capacity if they're deemed not to have capacity.
Yeah.
And I was
So
getting so frustrated with the doctor. I was
yeah.
like, he, he like, I mean, the man looked and acted drunk, and he wasn't drunk, but it's because of his disease process. And I'm like,
Mm.
this is ridiculous. And finally, that's why I was like, I'm just going to call security. I'm going to go in there, and we're just going to at least get an IV, at least get whatever. But yeah, I'm glad that you said that because I was just like, well, then just let him go if you're not going to let me do anything.
Yeah. I think for me, and it doesn't sound like this was the situation, but I agree with Michael. Like, if they're deemed to not have capacity, then they don't have the capacity to understand the consequences of refusing medicines. I think it's picking and choosing. Like, am I going to strap you down to put Colace in you? No.
Never.
Like, I'm not going to do it. But if it's like, I got to strap you down to, keep you safe or get this inotrope back on, like, then yeah, we have to do it. But then for me, the other piece too is the safety of the staff, right? Like, can we safely get him to a point where we can drop an NG tube so that we can force the medicines in him? And that's always kind of what I think too. It doesn't sound like that's the situation you were in, but I've been in other situations where they don't have capacity and they refuse and the family's there and then the family's like, well, mom doesn't want it. Okay, well, mom thinks she's on the moon. So I
Mom thinks it's 1960. Okay.
I mean this it actually just happened mom's delirious, not really waking up, and we need to get meds in her. So I'm like, drop an NG tube. And we're also prepping for a high risk CT and doing steroid prep and all of that.
Uh-huh.
And the family was like, well, we don't want the NG tube because we feel like that's too much. If she doesn't want her meds, like, that's too much. I'm like, your mom's yelling that she wants vegetables constantly. Like, I don't know she's not with it enough. But I'm like, that's fine. I don't disagree that maybe we're doing too much, but then I'm like, but you understand how high risk her CT is that we're getting. So do you want us to stop this part? Because the steroids we're giving probably aren't helping her delirium. And then and it was a back and forth, and it's like, no NG tube, but yeah, let's do this high risk CT. And it's like, and they just kept saying, well, mom doesn't want. I'm like, mom doesn't understand. And then I'm trapped because the family does have capacity. And it's like, well, I can't force it because you do have capacity and you're the power of attorney. And that sometimes gets really frustrating.
Mm-hmm. And that's when you just have to like document really well and say everything that you explained and that you told them the consequences.
Well,
that lady was
one of the things I always thought was interesting just in life to think about is we only ever worry if someone has capacity if they disagree with us, right? If someone just agrees with us the whole time, we're like, yeah, you want to, like, can we do this? Yep. And they may not, do they have capacity on the thing when you think about it? And then as soon as you want to do something and they say no, and then someone's like, well, do they have capacity to say no? And so it is something to be aware of. I mean, there has to be at some point where someone did not have capacity to make their own decisions, but they just happened to agree with everything you said. And so everything moved along fine. It was just like, yeah, they said we could do it. And so it's like, it is always those things. Cause like, I remember I had a patient who had heart surgery, full on heart surgery. And then they needed a pacemaker. And the nurse was like, they're slow. I don't think they have capacity to get consent for the pacemaker. And I'm like, yeah, just because somebody's not like intelligent, but they signed the consent for a cabbage 5 days ago or whatever. And that because the nurse didn't feel like the patient needed a pacemaker, it was like, well, I don't think that they have capacity to do it from like their mental intellect on the thing. And I was like, first of all, your intelligence level does not dictate whether or not you have capacity to make decisions on your body on stuff with it. It is interesting to think about it on the thing with it. That's just like, just you only seem to care if they don't agree with you from a capacity standpoint is how I typically see it.
I've not witnessed consents because physicians have gotten them from people who were absolutely not able to give consent. They're like, oh yeah, they signed it. I was like, I'm not signing it.
That's always an interesting thought. There's sometimes when I'm like, I think you have capacity, and I'll be like, let me just call your daughter quick and just let them know what I'm doing and kind of get like a secondary consent. But I mean, you're right. No one, if they say, yes, I'll do whatever you say, we really don't question it. And I remember I had a palliative meeting with a former palliative care APP and the family, and the kids were clearly drunk. They were drunk off their asses in the middle of the day. They were not coping well. And they were like, yeah, we want to withdraw on dad. He wouldn't want this. We're ready. And I'm like, yeah, you're going to have to sit in this room and sober up.
Yeah.
But the palliative care APP was like, they said it's time. They said it's time. Let's go. We're going to do it. And they got so mad at me that I was like, they're drunk. They're drunk. Like,
That's crazy. No, you can't go off of that. What in the world?
but I mean,
Should we just start doing psych evals on every patient and family member that comes in there?
I'm sure the psych team is so free to do that.
I mean, I wonder sometimes, I'm like, well, they drove up here. They've got a license, but my God, I don't know that they should be allowed to make these sorts of decisions for folks.
Yeah.
But
So I had a case I was like not involved in, but like like I was peripherally aware of. Patient came in with a STEMI, so they came to the emergency department with a heart attack, and they went into cardiogenic shock due to their STEMI, and ended up intubated on VA ECMO.
oof.
They coded, I believe, for a short amount of time. So they did kind of wait on sedation enough that he woke up and followed commands enough that it was like, okay, he's in there. But with the extent of the heart attack was like, he needs to go to a VAD or transplant center. And the family's coming in from wherever. You call the transplant center, they say, yep, seems like, or VAD center or whatever, and they say seems like a reasonable case, and they have a helicopter in the air that is 30 minutes away, and the family came in and they said, oh, he wouldn't want to be on life support, and talked to the doctor, and the doctor said, well, the family said he wouldn't want this, and they just stopped ECMO and withdrew, like with the helicopter, like almost to the on the ground on the thing,
like hovering above the hospital.
And so like, right, like the patient's yeah, the patient's intubated and sedated, right? So is not awake right then. And so then for me, it was always like, we knew the patient woke up and followed commands, right? Before we just like call it a day, what if we woke the patient up and talked to them while they're on the vent? Is that reliable enough to say like, hey, do you want this? Are you going to then override the family if you woke them up and asked them and they said yes? Like what decision? I didn't have to make the decision. It wasn't my patient, but it's just like one of those things that was like, he woke up and followed commands. He was sedated because they wanted to have him sedated for the helicopter ride. And then he was just gone. They just turned it off.
Wait a minute. Damn. Not even, I mean, I feel like I think they could have just waited and let him wake up and ask or something. But I mean, how many times, like, the stars have aligned, that he has followed commands. They have accepted him. There's a helicopter ready to go. Like, people wait for so long for that. And then they're like, nah, just pull the plug. He wouldn't want it. We're just going to cut the cord. Damn. That seems crazy.
Well, then I sometimes wonder, this kind of like sparked a thought, is like, in our state, you have to wait a certain amount to get divorced, or we all know there's so many people that like separate from their partners and then they never actually formally divorce, and then you're still that decision maker. Sometimes I'm like, when they're like, oh yeah, withdraw, I'm like, okay, but you, like, yes, legally you're the decision maker, but do you even know what they want? Like, those sometimes get a little questionable for me when they're like, I'm going to defer to, so and so, that's, I haven't been in their life, or we haven't talked, or we're super estranged. But sometimes like that situation is like, well, what was the relationship? Should you be making the decisions? Maybe that's just like a really dark thought that I'm like, maybe people.
That came up all the time pre-legalized gay marriage, where they were like, I've been living with this person for 30 years, but they are not legally allowed to make decisions. And then they're like, my second cousin is now the decision maker because that's the only family. And then you have to go based on the second cousin based on laws.
Mm-hmm.
Yeah, that's
Um,
crazy.
and so it is like you have somebody and they're like, we've been separated for 10 years. And they're like, well, you're technically the spouse. So, and most people are good people and they're like, well, I'm not going to make the decision, make, the whatever person, the sibling or the parent or the whatever. But there are people that are like, no, the decision is do this or do that. So,
Mhm.
Mm-hmm.
I love people
um,
just come out of the woodworks when somebody gets
yeah.
into the hospital.
Yeah.
Like, well, when's the last time oh, well, I haven't talked to them in like 10 years, but I'm here now. It's like, okay, this is sketchy.
We had this patient, I think it was last year, the year before last, that she was a donor case, and I came on, the night shift nurse had did all the work, CT, bronch, everything. The children had consented to everything. Donor services were there. The plan was to go to OR at like 4 o'clock in the afternoon. That was the tentative plan. And then the mom randomly showed up, and I don't think she was fully understanding what was going on. And so I had explained like what was going to happen. And she said, no, she wouldn't want to be cut up like that. And they canceled everything.
Oh my God.
So all of the work that the night shift nurse and everyone had done, it was just,
Why was she so late getting there?
I have no idea.
Interesting. I mean, for anybody listening who's not medical, please make sure your family members and your decision makers know what you would and wouldn't want. Like, actually, because people don't talk about it. And then they get into these situations and they're like, oh my gosh, I just don't know. And then usually they are relying on what we tell them is feasible or recommended. But that was just a side note PSA to
No,
people.
you have a great point. So my mom was always like, no, I don't want anything. DNR, DNI. If there's ever a chance I'm not going to be the person I was before, let me go. And I'm like, a chance? Like that is like nothing. Whereas
What's that
like
mean?
my dad has been on the opposite side of like, I guess if there's a chance, like you could like give me a shot on things. And so when my mom got sick, she had like pretty bad heart failure and pulmonary edema, volume overload. And it's just was, I was trying to explain to her like a ventilator for a cardiac arrest or a stroke or like a coma is a lot different than like a ventilator for I have some pulmonary edema and if you give me 2 days of Lasix or a day of Lasix, I'll come back off of it. And she was always just like, nope, never a ventilator, no matter what, under any circumstances. And
My kind of
it
lady.
was
I like it.
That's me.
and it always made me nervous. Like she'd be like, I'm getting admitted to the hospital for shortness of breath, and I would just be like, oh, I hope like they give her enough diuretics or BiPAP or like because there is zero wiggle room. It was just like absolutely not.
But you knew it and you would have, honored her what
I
she
mean,
wanted.
yeah, I mean, I would have
Uh,
honored it. It would have
and
been like hard on the thing to be like, really, like all you need is just like 12
12
hours,
hours.
24
Mhm.
hours.
Mm.
You'll be really
But
comfy.
Yeah, no, DNR,
yeah,
done. Let me go.
That's me. Sorry. I'm like,
My mom
hang
tried
now.
to pull that shit with
Done.
me. She's going to have like just no surgery is really routine, but like a laparoscopic surgery. She's like, just remember, I'm a DNR. You have my paperwork. I was like, Mom, okay, well, they're not gonna let you go into the OR, first of all.
Yeah.
Like, but I was like, I know what you want. Just relax. Like, and you're gonna be fine. My God, like the dramatics. But I do know what she wants, and I am her, legal appointed person to execute that, and I would honor it. But it's like people don't, I don't know if they don't think about it or they don't want to talk about it, or they just assume that people know, but they don't. And then, like you said, you have to rely on the medical professionals and experts to tell you, some people trust us and some people
yeah, because
don't.
I had conversations with my mom. She had terminal cancer, and so we like throughout the years had conversations about what she wanted and stuff. But I also told her I would make the right decision. I wasn't going to let her be on a ventilator the rest of her life. But when she did get sick that last time, it from the time she got to the hospital to the time she passed, everything happened so fast. So I can. So if you don't know those wishes, you're having to make decisions immediately that if you make the wrong one,
Mhm.
then
Yep.
And when I don't agree with a decision, that's what I kind of remind myself, though, is like, this person has to live and look at themselves in 5
Mhm.
years, and with they're making the best decision that they think that they're making, and I might not agree with it because I'm do not intubate ever, but
To piggyback off of that, when my mom was in the hospital, I wanted to make her DNR and DNI and like for the whole time, but my brother was all the way in Texas, and I told him to keep her full code until all the children could
Hmm.
get to
yeah.
her. And then, of course, I made her DNR, DNI. But in that brief moment to keep her full
Mhm.
covered, I didn't want,
Hmm.
if her heart were to stop, I didn't want them to beat on her
Yeah.
chest and everything.
But you're letting them know.
I also had previously told my brother, "Oh no, she'll be fine." That morning, to have
Nice.
that guilt,
Yeah.
I've
Yeah.
look at him the rest of my life and be like,
But
"Sorry."
like you're talking about it, Michael's talking about how hard it was, and you guys, I mean, you do know because that's where you work. That's
Yeah.
your whole. I mean, you know everything, and it's still tough for just the average person with no medical knowledge. Like that's got to be so scary and intimidating. But that's what I wish people would understand that, like when we're giving you like a plan or whatever, I mean, it's with the best interest with all of our knowledge that we have, and we're trying to do the best thing that we know to do for the patient, whether that is escalating care or de-escalating sometimes.
Mm.
Mhm.
And I'd say 99% of the medical professionals out there do have the patient's best interest at heart and just want to do right by them.
I know that I've had instances uh where I'm talking to the husband, let's say, and I'll be like, "Oh," and they were like, "She always said she wanted to be like DNR, but I'm not ready for that, so she's full code." And so then like if you go by the what I believe to be the letter of the law is you should go by what the patient wants, right? Not what he's letting you know that she wants to be DNR,
Yep.
like you should be like, well, that it's not really about you, so I'm going to make the patient DNR if that's what she wants to be. And I've even had it where they had it written somewhere, and then the family is like, well, we're not going to agree to that. And then I'm like, well, you don't really have a choice. And then it's gone to like ethics, and then they're basically like, it's what the family wants. And then
Yeah.
you're kind of stuck with this thing of like, we know what the patient wanted, but you now have to do what the family wants.
Hmm.
And that has been hard. Luckily, it's been so few amount of times. It doesn't happen like regularly where like you can't hopefully do like the best interest for the patient. But that has come up where they will flat out say they know what their family member would want, and they're going to go against it. And you're helpless in that situation.
That shit pisses me off.
Okay, I have a question. Have any of you guys, I don't know if you've ever been like admitted in the hospital for anything, but have you ever refused something that your doctor recommended or your provider?
I have.
Uh, okay.
Well, when I was in Costa Rica, with my nursing school, I got dengue fever, and my blood counts got really, really low, and I was receiving healthcare there, and I refused blood transfusions there.
Why?
A little bit of mistrust. I'm in a foreign country. I didn't even know my blood type at that time. Actually still don't know my blood type.
What?
Jesus.
They made
I've
us do
never
that in
been
high school.
I've never been allowed to donate. Um, I don't know. I was young. I was scared.
Does that give you like more empathy for people?
Yeah, I think it's for me, I think the biggest thing I took from it was when you don't speak the primary language. Like I had been studying Spanish, medical Spanish. I was working in this clinic as a nursing student. So I could speak medical Spanish. And when you're that sick, when it's not your primary language, you can barely think I could barely think in English, let alone translating
Mhm.
what they were saying to me. And so I do have more empathy for people when English is not their primary language and they're here. because they could be here 10 years and they could speak English fine in their day-to-day life. But when you're that sick, it is so hard to process it. And having been on the other side, and then you just have people, I mean, putting IVs in you, they're handing me, my lab work, and I'm like, yeah, I'm still a nursing student too. I think it would be different now, but I survived. I was fine.
I refused some
So-
meds when I was admitted to have my babies.
Yeah.
The first time I refused my Ambien that they tried to give me because I didn't want to fall. The second time, best believe I took that. I was like, are you going to bring that? What time is that coming? Because I ain't slept in 10 months. And then I also refused my prenatal vitamins and ibuprofen because I was like, you ain't charging me $300 for that. But I have it in my purse. And I told the nurses, I said, I'll take my meds, but I don't want that on my bill. So I did that. But that's all I can think. Look, I'm just saying, you know how much that shit they charge for that? I'm like, I got a bottle. I promise I'll take it. No? Okay. Just me.
I haven't been in the hospital enough to like refuse something. So I can't speak to it on the
Fair.
thing with it, but
Okay. I was just curious.
Mine probably delayed my healing a little bit.
You think? Dengue fever?
Yeah. But I got so skinny. It was so great. I was so little the rest of the summer.
Where'd you go again?
I was in Costa Rica doing
She's
like a
But I
study,
look good.
doing a study abroad program. So we would go down. My nursing school went down.
No, I can't afford that. I already have low platelets. I don't want to die in Costa Rica.
And they got to 8. Well, any final thoughts on patients refusing care?
It's your body, your choice. Make sure your loved ones know what you would want.
Yeah. And that they'll follow through on what you want to.
Yes.
Well, from all of us here at Banter at the Bedside, it was great having you, and we'll talk to you soon. Bye.
Bye.
If this felt like your kind of conversation, make sure you're following, leave us a review, and we'll see you back here soon. Bye.
Step into the light where the stories hum.